Hi everyone. Today we are going to discuss a very important topic in neuromusculoskeletal physiotherapy, common nerve palsy, common peroneal nerve palsy. Okay, shall we start? Now, why it is important? Because this is one of the most frequent injury in peripheral nerves. As a future clinician, recognizing and managing these conditions early can prevent long-term disabilities. The common peroneal nerve is a branch of sciatic nerve, and it is injury typically present with key clinical signs of foot drop. Let's dive deeper and we can notice it. First, we can use of anatomical overview. The common peroneal nerve is a smaller branch of sciatic nerve and runs along the lateral side of the popliteal fossa, wrapping around the neck of the fibula. It divides into two branches: superficial common peroneal nerve, deep peroneal nerve. This is an anatomical pathway, especially where it wraps around the fibular neck, is where it becomes most vulnerable to the injury. Functional anatomy. Let's understand what these branches do. Superficial peroneal nerve supplies motor peroneus longus, uh, peroneus longus and brevis. This helps in eversions. Sensory to skin over the dorsum of the foot. Deep peroneal nerve supplies motor tibialis anterior, extensor hallucis longus, extensor digitorum longus, peroneus teres, responsible for dorsiflexions. Sensory response for uh, first web space of the foot. Understanding this help us to correlate the specific motor and sensory loss to the level of the injury. The vulnerability of the injury. The common peroneal nerve is extremely superficial and fixed at fibular neck, which makes it prone to direct trauma. Um, the compression injury, tight plaster, and prolonged pressure, stretching during the dislocations or surgeries. This explains why the patients after the hip or knee surgery sometimes common back pain with the foot drop. Etiology. What is the etiology? The general and local causes are, now let us talk about the causes. General causes include leprosy, diabetes, toxins, autoimmune disease, tumors. Yes, it is still major cause for the some regions. The local causes can occur at the multiple levels of spine, disc prolapse, tumors, hip regions of dislocations and fractures, knee lateral condylar fracture, dislocations, cast, surgical complications like TKR. What are the clinical representations? Clinically, you will see foot drop patients can't dorsiflex with the foot, high stepping gait to avoid toe dragging, sensory loss over the dorsum or the first web space. The muscle atrophy can occur, especially at the compartment of anterior muscles. Uh, Always examine the gait and the muscle strength carefully in suspected cases. The lesions, when you come to the lesions, we can classify into high lesions and low lesions. High level lesions are involving both tibial and peroneal nerves, usually above the knee. The low level lesions are usually at the fibular neck. The low level lesions are further divided into two types: deep peroneal nerve and type 2 are superficial peroneal nerve. Deep peroneal nerve are weak dorsiflexions, web space sensory losses. And the superficial peroneal nerve are weak eversions and sensory loss on the lateral dorsum of the foot. Coming to the point, there are two types on the lower lesions: deep peroneal nerve and superficial peroneal nerve. Deep peroneal supports to the weak dorsiflexions and web space sensory losses, and superficial peroneal nerve weak eversions and sensory loss on the lateral dorsum of the foot. On the diagnostic tools, what are the diagnostic tools are? Clinically, check the gait and muscle test. Manual check the muscles and provide the progression of the foot. Tinel signs, tap of the fibular neck to check the tingling sensations, and the EMG and NCS to assess the nerve functions. Nerve stimulation test and nerve functions test. The MRI or the X-rays to identify the fractures or space occupying the lesions. What are the physiotherapy on acute stage? In acute stage, our goals are prevent deformity, maintaining joint mobility, prevent pressure sores. We use angle foot arthrosis to prevent foot drop and equinus varus. A passive range of motion exercise to maintain the joint integrity, proper positioning to avoid pressure of injuries, which may get pressure to the fibular neck to get a may get injury to the common peroneal nerve. What are subacute chronic managements are? In later stage, we focus on electrical stimulation for the muscle and re-education, strengthening exercise, partially inverted muscles, maintaining gait for orthosis, balance and proprioception exercise. Patient may educate skin scars, especially of the sensory losses. When to consider surgery, the surgical protocols may be considered at in the stage of if there is no recovery after 12 to 18 months, our surgical options may be considered. The nerve repair or grafting, tendon transfers, example by tibialis posterior tendon to restore the dorsiflexions, neurolysis or decompression of the nerves, joint stabilization in the cervical severe cases. Um, what are the progressions? Recovery depends on the age, um, site of injury and severity of the injury, type of lesions, earlier interventions. That brings us to the end of our sessions. The common peroneal nerve palsy. Remember, early diagnosis, appropriate physiotherapy, and patient with education can make a huge difference in the patient outcomes. Thank you for your attention.